So today we're going to start with our eye examination. So we start by looking at the eyelids and the eyebrows and eyelashes just to make sure there's even distribution on the eyebrows and the eyelid or the eyelashes. Make sure again there's no bugs in hairs because it happens. Distribution is good. Yes. Then we'll look for entropic and ectropic, which is turning of the eyelids either in or out, which they are not, because that can cause irritation and dryness because either the eyelashes are touching the eyes or the eyes are flipped inside out, the eyelids are, and it causes the eyelids to dry out. Yes, it's a thing, it happens, I've seen it. So then we're going to check for the sclera, which is the white portion of the eye. We check it for clarity to make sure it's bright white, there's no redness, no inflammation, no irritations. Your whites are good. So then the irises, which is the colored portion, we'll check for symmetry and color. So your green hazel. And they are very clear and they're both symmetrical. So then we will check the conjunctiva and the corneas. So for corneas, which is the covering of the eyelid, iris and the pupil, we check from this side, so have you look straight ahead. So you can see it's clear, there's no clouding, there's no scrapes or irritation on that. So then for the conjunctiva, have you look straight ahead at me, and then we basically just grab down a little bit to check under, check for, it should be pink, not dry, same thing on the top. Okay. So that is the conjunctiva, which should not have any discharge, and it should not be bright red, but it should also be pink and well, make sure the vascular is correct. So that's those. The global tonus. So we check for the pressure. So have you close your eyes for me and just gently press over the eye to make sure it's firm, there's no soft spots, and it's not giving, so there's no leaking or anything that we need to check on that front. So then we will check the lacrimal glands, lacrimals.
Sorry, I'm stuck on my eyeballs leaking, go ahead.
So that actually leads into the tear ducts. So it comes from the inner, or from the outside of the eyebrow. We're checking for tenderness there, and it comes actually down to the nose. So there's no tenderness, correct? No tenderness? No, okay. There's no discharge when we push on that gland either, which is important. So now we will check the pupillary reflexes. So we will make sure first off that the pupils are symmetrical, which they are, which is good. They're not blown, they're both equal and round. So then we will check for light reaction. So when we shine in one eye, it should contract, which it does. And then when we shine in that same eye, we can watch the other one, and the other eye should contract as well. Also good. So, and that's also again the equal contraction in both. So then we will check for accommodation. So have you look at my finger out here. And then as we go in, the eyes should cross and the pupils should constrict, which they do. So then we will check the extraocular muscular functions. So for those, we will check the control reflex, which is, so the corneal reflex. If you look straight at me when we shine, there should be the same spot of light reflection in both eyes. So that's the corneal reflex. So that is good. And then we will do the position test, the 6 cardinal positions. So I'll have you follow, have you look up. And where it goes up, out, and down. The movement is equal. There's no jumping or twitching while we move. And then we will do a cover test to check for lazy eye. So I'll cover here. Have you look straight ahead at me? Okay. That's good. Same here. Look straight ahead. And good. So should she have a lazy eye, when I uncover, I can watch the one that was covered jump back up, because if it was lazy, when you cover it, it relaxes the muscles and allows the eye to droop. So then when you uncover it, it will drop back to focus. So then we will do the central visual acuity. So for that, we would do the distance, which would be the Snellen charts. So I'd take her out, have her stand 20 feet from the chart, and then have her read the lowest line she can with both eyes open. We would mark that down at the number, which is on the side of the chart, which are distance based on 20 feet. So if it's greater, it would be 40, 20, so it's whatever the number is based on a 20-foot radius in a normal vision. So perfect vision is 20, 20, so you can read at 20 feet what most people can read at 20 feet. Then we would cover one eye, do the same thing, lowest line possible, and then do the opposite eye up. So for near vision, it's actually a card that we typically don't do in a clinical setting. It's like a computer card. And then we'll do peripheral vision. So I'll have you look at me, go behind her, and have her, when she can see my finger move. Okay, and over here. Yep. Okay, and that should be about 90. That's normal peripherals. So that is eyes. So we will move on now to ears. So for that, we will check size and symmetry. Check your little flex.
My hair grew out. We get it pressed back off.
But so we make sure they're pretty well symmetrical and they're not like overly large or tiny. Make sure they are almost vertical on the head, which they are, and make sure you do have a little droop. But make sure that they are also in line with the outer campus of the eyes, which they are. So that the position is vertical. So the external auditory meatus, which is the outer portion of the ear here, just the whole outer portion of it. Make sure there's no redness, no inflammation, no swelling, no tenderness. So let's check on those, make sure everything looks okay. So we check the external, so then we will check the tragus, which is the little piece right here. Here's super tiny, but also make sure there's no redness, no inflammation.
What was it called?
The tragus. Oh. People get piercings in the tragus. And then we will also check the mastoid processes, which are right behind the ears. There's a little bony prominence there. Make sure that's not tender, no swelling, not tender. Okay. So then with that, we will do the voice test. So I will go behind you. I will have you cover the opposite ear from me. And and then I'll whisper a 2-syllable word and have you tell me what that word is. So baseball.
Baseball.
Okay. Check the other ear. Hopscotch.
Hopscotch.
Okay. So we will do that. So then the Weber's test, we use tuning forks for, which we don't have here unfortunately. But so for that, you would ring it against your hand, you place it on the top of the skull, and ask them if they hear it more in the one ear or the other.
Okay.
So ask if you hear it more in one ear or the other, and normal, it should be the same in both ears. And then we did physiology.
Let's try that.
And then we would do the Renee's test, which for that, you would, again, ring the fork, hold it in front of the ear until they can no longer hear it, and then place it on the mastoid process, and then they should be able to hear it again, but this should be for less time because air conduction should be longer than bone conduction is.
Interesting, yeah.
So those are for that. So then when we would use the otoscope, which we also don't have, you would hold it sideways between your first finger and your thumb, and you use your pinky to brace against their head, so you don't end up wobbling in their ear. But when you do it, you would pull the ear back and up, so you can get in without hurting your ears. For children, you pull straight down.
What's the thing to look in your ear?
With you, make sure you have your covers on those too.
Oh yeah.
So that's how we would use that, and then we would use that to examine the tympanic membrane, which should be gray. One of the only things in human people that should be gray. But there should be the cone of light, And the cone in the right ear should be at about 4 o'clock, and in the left ear should be at about 8 o'clock. So just examine that, make sure it's not red, make sure it's kind of translucent, and there's no lesions or sores on that. So that's our ear exam. So we will move on to nose, mouth, and throat. So, for that we will start with the nose. So we'll check the outer configuration, make sure it's midline in the face, it's symmetrical, there's no deviations. These are good. So then we would check the nasal cavity. We would again use our otoscope light with a new cover on it to check their nose. So we would examine inside the nasal cavities. So for that we would check, while we're in there, we would check the septum, and we would check the tubercles. So those we could see the inner and, we can see the first two, the inferior and the middle. There's a third one but it's too far up, we can't see it. So we would just examine those, make sure that there's no deviation in the septum, make sure the cavity is well vascularized, so it should be pink, should be no lesions, no sores. So then we'll move on to palpation. So we will check the bilateral patency of the nose. So I'll have you take a deep breath for me. Okay. And then we'll occlude one nostril. Have you breathe again for me? Okay. And the same. Okay. Just to make sure that there's no blockage in one side versus the other. So if like you're really congested, you can't breathe out of one side. So that's what that's looking for. So then we will check the frontal sinuses, which are right kind of at or below the eyebrows. So just press on that, make sure there's no tenderness. Good. And then we will check the maxillary sinuses, which are right below the eyes, kind of right along the cheekbones. Check that for tenderness as well. So then we can do transillumination of the frontal and maxillary sinuses, which we can't do here, and we often don't do in clinical settings unless it's like an ENT doc, so we won't do those. But we would actually, you can, in a really, really dark room, shine a light on the roof of your mouth, and it'll light up these sinuses. And then if you get a light up into the nasal cavities, it will light up these.
No way.
If they're clear.
No way.
We're gonna try to work one day. So then we'll move on to the mouth. So we'll inspect the lips for cracking, lesions, make sure they have good color to them. Okay.
Yeah, sorry. I'm sleepy.
And then my non-tongue depressor, tongue depressor. And then we'll look at the teeth and gums while we're here. So we'll just kind of make sure there's no cracks, no missing teeth. Make sure the gums have good color and they're not retracted. Your gums are always pale, but that's normal for you. So then while we're doing that, we're also checking just the mouth mucosa as well to make sure, again, the color is all well. And then we also check the palate. So if you open your mouth again for me. So the hard and the soft palate should also both have good color to them, which they do. So then we will move on to the tongue. So have you stick your tongue out for me. Make sure it stays midline. Okay. And then there's no tremors or anything. So for muscle strength, have you stick your tongue in again. And then press against me. Okay. And again. Press against. Good. So there's that. And then for cranial nerves 9 and 10, I'll have you open your mouth and say ah for me. Okay. When you do that, your uvula should rise, just cranial nerve 10, and it does. So that's good. Those are sensory motor nerves. And then for 9 and 10 as well, we would also do more taste sensors, and we would do gag reflexes, but I'm not going to gag you. Gag you. But those also will check for those nerves. And then for the tonsils, have you again stick out for me? And say ah again. Can't see. Alright. Okay, so no swelling in the tonsils, which would make them a +1, which is normal. We don't want anything above that.
Yeah.
If you don't have tonsils, it's a 0. +4s are real bad. So we're gonna move on now to our respiratory. So for that, we are just going to, in general, check the chest. The dimensions should be 2 to 1. So 2 here to 1 on the side, which it is. Because barrel chested with like CHF, they have almost a 2 to 2 because the chest expands to hold extra air.
No.
And we're looking for signs for respiratory distress. You don't have nasal flaring. You're not tensing muscles to breathe. You're not cyanotic, which is real good. Flu is bad on people. So there's that. And then your respirations are even and normal. We would count normal respirations when we do initial vitals when you come in. And those should be between 18 and 20. So then in general, we're going to just palpate the front of your chest. I'm going to take these from you. Make sure there's no tenderness, no lumps, no swelling. No sides. So no tenderness, there's no lumps. Then there's symmetrical expansion, so take a deep breath for me. Okay, symmetrical. Symmetrical is always good. So then we're gonna percuss on the chest. So with that, we'll do 10 to 12 places. So we always go across and down, just to make sure it's the same on both sides. So we'll start over here. Just checking for make sure it kind of sounds the same on both sides. There should be no really sharp sounds. Okay, and we'll do that in roughly 8 different places while we're doing our exams. So then we will you're fine. So yeah, that'll be 10 to 12. We're also gonna have you look for tactiles. So I'll have you say 99 for me.
99.
Okay, again.
99.
Again.
99. 99.
Okay, and that is just a gentle vibration across the hands while she does that. We don't want really strong vibrations or no vibrations because that is a sign that something's very wrong. And that is 6 to 8 across the chest. With that, we did our percussions, we did palpations. So now we are going to listen. So while we're listening, we're going to start at the apices of the chest, which is right above the clavicles. So we're going to listen to bronchial, bronchiovascular, and then, or bronchoventricular, sorry, and then the vesiculars. So the bronchioles should be sharp, right against the neck. Breathe deep for me. And again. Okay, bronchiovesiculars. Go ahead. Again for me. And we would do that in 10 to 12 different locations on the entire lung field, but we're not going to make her hyperventilate today. So we're listening for abnormal breath sounds or advantageous sounds, which would be crackles, wheezes, any of that, which we don't hear. She sounds very clear right now, which is good. We're also going to listen for friction rubs, which means your lungs collapsed. Also don't want that. That's when you get to continue. So then we're going to move to the posterior side of the chest. I'm going to take this with me. So on the posterior chest, we're gonna do the same thing. We're gonna feel for any lesions, any tenderness. If you're not really feeling anything sore to you.
Yeah.
And then we're also gonna do our, so have you take a deep breath again for me? Hold it in a second.
I guess you could have just taken that one. Okay. You ready?
Yep. Okay, again, it's symmetrical. There's no signs of distress. She's not using her trapezius muscles to breathe at all, and there's no rib movement down here, which would be signs of distress. Again, we're gonna do our tactile. So have you seen 99 again for me?
99.
Okay, again.
99. 99.
You're too high. And again.
99.
Okay. So again, those are gonna be 8 to 10 different places along your person. We did symmetrical expansion. We're going to do our percussion again. Since the back, you have more room, it's gonna be 14 to 18 locations. So here, let me just. So we would do that in 14 to 18 locations over the entirety of the back of the lung fields. So then that's our resonance exam. So then again, we're gonna do our oscillation, starting at the apices. We're gonna listen again. So we would do our bronchiovesiculars in the intercostal space of 1 and 2, which is gonna be right around up here. So have you again breathe for me. And again. And we would do that again over the entire lung field. But again, we're not making her hyperventilate today, so.